Hello. On behalf of CME Outfitters, I would like to welcome and thank you for joining us for this first CE activity in this three-part CMEO briefcase series titled Rethinking Standing Orders to Manage Pain in Adolescents and Young Adults Requiring Third Molar Extractions. Today's case is focused on assessing and perhaps reconsidering some of the pain management standing orders that you have in place for third molar extractions in adolescents and young adults. I'm Mona Saragi. I'm a dentist anesthesiologist and a diplomate of the American Dental Board of Anesthesiology. I'm the director of the Dental Anesthesiology Residency Program at Jacobi Medical Center and assistant professor of dentistry at the Albert Einstein College of Medicine in the Bronx, New York. Let's start with an overview of our goal for today's activity. Our learning objective is to apply evidence and guideline recommendations supporting non-opioid pain management to treatment decision-making. Let's get started with our case and meet Neil. Neil is a 19-year-old male. He complains of moderate pain that is occasionally severe. Upon physical examination, it is revealed that there is inflamed tissue surrounding a partially erupted mandibular third molar. Radiographic examination confirms that the tooth is partially bony impacted. Our clinical diagnosis is that this tooth is impacted with acute pericoronitis, and Neil is scheduled for third molar extraction. So I'd like to start by understanding your standing orders for a typical prescription for pain related to third molar extraction. So what are your standing orders or typical prescriptions for pain related to third molar extraction? So now let's see how your opioid practices compare to other providers. In a survey of 384 randomly selected oral surgeons, almost all, or 382, stated that they prescribed opioids. On average, 20 tablets were prescribed. 22% of respondents said that they prescribed more than 20 tablets, and 11% reported prescribing more than 30 tablets. Most respondents reported using adjunctive analgesic strategies to supplement opioid use. If you have ever wondered if there's a variation in opioid prescribing before a weekend or holiday, then you're right. A study evaluating a retrospective cohort of over 2 million patients found that patients having procedures before a weekend or holiday had a 27% increased odds of filling a prescription for an opioid. The graph here demonstrates this trend. The procedures listed on the left, and you can see that surgical extractions are at the top. The blue bars are the proportion of patients filling their opioid prescriptions before a weekend or holiday, and the green bars are the proportion of patients filling their prescriptions on days not preceding a weekend or holiday. For the surgical extractions, around 65% of patients fill their opioid prescriptions before a weekend or holiday, but around 55% on a weekday. The asterisks indicate that the finding was statistically significant, and you can see this trend holds up for most procedures. What can we take away from this? Patients want to be out of pain, especially during a weekend or holiday when it may be difficult to see the doctor should any complications arise. Now that we know that there's an uptick in prescribing before the holiday or weekend, we have to ask, how many pills are needed prior to third molar extraction? This study evaluated how many prescriptions were made for patients and how many of these opioids were actually consumed by patients. 38.4% of the prescribed medications were consumed during the study period, leaving over 60% of the pills as potential leftovers. After adjusting for the relative doses and potencies of the different opioids, such as hydrocodone versus oxycodone and so on, it was determined that 6 to 7 tablets of opioids may be sufficient to manage pain for most patients. As we will discuss, post-surgical dental pain is driven primarily by inflammation, the key mediators of which are prostaglandins. So the anti-inflammatory medications will help combat the actual mechanism of inflammation and pain, and those 6 to 7 tablets of opioids may be all that the patient needs to overcome the most serious, severe breakthrough pain. We also know that the typical course of adenogenetic pain is 3 to 5 days, so a limited opioid prescription is prudent to treat severe breakthrough pain and get the patient back in the office for a follow-up visit should the pain not resolve. Without a doubt, most of us became dentists in order to help alleviate the pain our patients experience, and most of us take great care to ensure our patients feel little to no discomfort whenever possible. However, we have to watch out for the unintended harm of our prescriptions. Dr. Paul Moore said it best when he said that every year, millions of adolescents receive their first introduction to opioids following the extraction of their third molars. Many of these young adults have never received these centrally acting analgesics before in their lives. So we have a special responsibility to counsel them about the dangers and educate them about the safe use of opioids when taken for acute postoperative pain. Let's take a look at opioid prescribing by specialty. Dentists are amongst the leading prescribers for opioids by specialty. To the right, we see that the dentists lead all specialties in new prescriptions, as indicated by the bars in purple, but with lower continuing prescriptions in gray. This makes sense, as for the most part, procedures such as wisdom tooth extractions are often a one-time procedure, but there could be repeat prescriptions for patients who have ongoing stage treatment plans for multiple procedures. To the left, we can see the breakdown of specialists by age category. You can see that for children under the age of 10 years, the ear, nose, and throat physicians, or ENT physicians, lead the way. And this correlates with children who are getting their tonsils and adenoids removed. But for ages 10 to 19, the dentists, which are in green, are leading the pack. And this correlates with the age for wisdom tooth procedures. So we have to be very mindful that we may be the ones prescribing that first exposure to opioids in this young population. Dentists are number 2 in ages 20 to 29. So there are probably some extractions and implant procedures, but now the general practice physicians are leading the way. And by age 30 to 39, it's primarily orthopedic surgery. So if we are to treat post-surgical dental pain in a rational and evidence-based manner, then we need to understand the mechanism underlying dental pain. Post-surgical dental pain is driven mainly by inflammation. So to perform an extraction, especially a partially impacted wisdom tooth, one needs to create a flap, remove some bone, and so there's trauma to both hard and soft tissue. When the cells are damaged, an enzyme called phospholipase A2 can liberate a fatty acid called arachidonic acid from the damaged cell membranes. The cyclooxygenase enzymes called COX-1 and COX-2 then metabolize arachidonic acid to a variety of inflammatory mediators called prostaglandins. The prostaglandins are among the key mediators of pain. They sensitize the free nerve endings at the surgical site, thus enhancing the transmission of pain signals to the central nervous system. NSAIDs such as ibuprofen block COX-1 and COX-2. COX-1 and COX-2 have complementary actions. COX-1 was previously referred to as the constitutive pathway, and COX-2 was previously referred to as the inducible pathway, but some COX-2 effects are constitutive. COX-1 produces prostaglandins and thromboxanes. These mediators promote protection of the stomach lining, platelet aggregation, vasoconstriction, and also regulate renal function. By inhibiting COX-1, you lose these effects of the prostaglandins and thromboxanes. So patients are at risk for not only GI irritation, but ulceration and bleeds, and they can also interfere with the effects of antihypertensive medications due to the loss of the prostaglandins effects on the kidneys. Also, if medications are excreted by the kidneys, interference with renal function could lead to the dangerous buildup of these medications in the blood. And lithium is an example of that because it's a drug that's almost excreted completely unchanged by the kidneys. The prostaglandins on the COX-2 side also regulate renal function, and the COX-2 has complementary effects with regards to inhibiting platelet aggregation. So actually by blocking COX-2, you're going to promote the risk of growing clot. COX-2 prostaglandins also mediate fever, pain, and inflammation, which is important in the treatment of pain. Multimodal analgesia is a buzzword in the age of the opioid epidemic, but it is something that dentists have been doing for a long time. Multimodal analgesia, as its name implies, means that we are providing analgesia and multiple inputs on the pain pathways and therefore achieving synergistic analgesia by utilizing lower doses of medications from different drug classes, and this can reduce opioid requirements. What do we as dentists do for almost any procedure? We get the patient numb. So local anesthetics can act by blocking sodium channels and preventing the transmission of painful responses from the site of injury or surgery to the central nervous system. There are a few exceptions to this. There may be patients who have a true local anesthetic allergy and or the patient might be unconscious because they're under general anesthesia, but we absolutely need local for almost all procedures. Profound local anesthetics and long-acting local anesthetics, such as bupivacaine, can block the transmission of nociceptive inputs along A delta and C fibers to the central nervous system for hours postoperatively, and this will help reduce the pain. The A delta or C fibers are going to carry the pain signal to the central nervous system, and since they're the first neuron to go from the site of injury to the CNS, we call them primary afferents. The primary afferents enter the dorsal root ganglion as seen here and communicate or synapse with the secondary afferent neuron in the dorsal horn of the spinal cord. The primary afferent releases substance P. The secondary afferent then crosses to the other side of the spinal cord and synapses with third order and fourth order neurons, which can eventually sense or feel pain. NSAIDs act by blocking cyclooxygenase enzymes, which produce prostaglandins. The prostaglandins sensitize free nerve endings at the site of tissue injury or trauma or surgery. So by reducing the production of these prostaglandins, we'd reduce pain by interfering with the mechanism of action for the pain. Although the mechanism of action for acetaminophen is not fully understood, it's thought that acetaminophen is a weak inhibitor of COX-1 and COX-2. But unlike the NSAIDs, which block COX in the actual substrate binding channel, acetaminophen disrupts COX electron transfer. In other words, acetaminophen acts on COX, but in a way that's different from what we know about NSAIDs blocking the production of prostaglandins. Although the mechanism of action of acetaminophen is not fully understood, it is thought that acetaminophen is a weak inhibitor of COX-1 and COX-2. But unlike NSAIDs, which block the COX enzyme in the substrate binding channel, meaning they prevent the production of prostaglandins, acetaminophen works somewhere in the catalytic center by disrupting electron transfer. In other words, acetaminophen acts on COX, but in a way that's different. There are also proposed centrally acting mechanisms for acetaminophen as well. Acetaminophen has a different mechanism of action and therefore a different side effect profile. So acetaminophen will not cause bleeding, gastrointestinal upset, or renal dysfunction, but rather the main concern is liver toxicity. And therefore, we can add acetaminophen to ibuprofen for a synergistic analgesic effect. Lastly, we have opioids, and opioids act mostly centrally. So opioids are not going to interfere with the mechanism or cause of the pain, but rather they're going to reduce the awareness of pain centrally. They're also going to activate descending analgesic pathways, pathways that descend from the CNS down to the spinal cord and inhibit the release of substance P by the primary afferent neuron. And the side effects include nausea, vomiting, constipation, sedation, and respiratory depression. Another concept that you should be aware of is something called the NNT, or the numbers needed to treat. So the numbers needed to treat mean that you need to treat a certain number of people to see a certain effect in one person. And so for these pain medications, the numbers needed to treat is for one person to achieve 50% pain relief. The ideal numbers needed to treat, or NNT, is 1, because that means that everyone who gets treated achieves the desired effect. For oxycodone 15 milligrams, 4.6 people need to be treated for just one person to feel pain relief of 50%. So one person will experience at least 50% pain relief, and the other 3 or 4 people may still experience the unpleasant side effects, or potentially worse, be exposed to opioids and be that patient who is at risk for addiction. And for the ibuprofen 250 milligram and acetaminophen 500 milligram combination to the right, you can see that the NNT drops to 1.6, which is pretty close to the ideal NNT, which is 1. Here are the evidence-based recommendations for prescribing analgesics for acute pain in dentistry. To the left, we have a column that describes mild, moderate, and severe pain and includes examples of the typical procedures that produce such pain. So a simple extraction or routine endodontics, such as a root canal therapy, may result in moderate pain, while surgical extraction or quadrant periodontal surgery with flaps and bony recontouring may cause moderate pain. And severe pain may result from partial bony or full bony impaction surgeries. This is not a comprehensive list, but it's meant to be a guide. And certainly there may be individual variation on how each patient experiences pain. The treatment algorithm for patients who can tolerate NSAID therapy is in the center column. For mild pain, the regimen is ibuprofen 200 to 400 milligrams every 4 to 6 hours as needed for pain. Now, if the pain relief is inadequate, or if you're starting off with anticipated moderate pain, then you can prescribe ibuprofen 400 to 600 milligrams every 4 to 6 hours for 24 hours. So instruct the patient to take the meds around the clock for the first day, and then switch to ibuprofen 400 milligrams every 4 to 6 hours on an as needed for pain basis. Again, if your patient reports inadequate pain relief or you foresee moderate to severe pain, now we would add acetaminophen. So you would take ibuprofen 400 to 600 milligrams with acetaminophen 500 milligrams every 6 hours, and you would take this again around the clock for the first day, and then have ibuprofen 400 milligrams every 4 to 6 hours on an as needed for pain basis. For severe pain, you can have the patient take ibuprofen 400 to 600 milligrams every 6 hours around the clock for the first 2 days. You can also prescribe a combination of acetaminophen 650 milligrams and hydrocodone 10 milligrams and have the patient take that every 6 hours for the first 2 days. After the first 2 days, you can switch to ibuprofen 400 milligrams every 4 to 6 hours as needed for pain. Now, you might have some patients where NSAIDs are contraindicated, and we'll get into the contraindications in just a minute, but the regimen is slightly modified. So for mild pain, one would start off with acetaminophen 650 to 1000 milligrams every 6 hours as needed for pain. For moderate pain, it would be acetaminophen 650 with hydrocodone 10 milligrams every 6 hours around the clock for the first day, followed by acetaminophen 650 to 1000 milligrams every 6 hours, again, as needed for pain. And then for severe pain, patients would start on acetaminophen 650 milligrams with oxycodone 10 milligrams every 6 hours around the clock for the first 2 days, followed by acetaminophen 650 milligrams to 1000 milligrams every 6 hours as needed for pain. So some key points about dosing. Patients should be warned about acetaminophen. The maximum daily dose is 3000 milligrams. There's a risk for inadvertent or accidental acetaminophen overdose because acetaminophen is found in a lot of formulations. Patients may not realize that the Vicodin or Percocet they're taking has acetaminophen in it, or that the over-the-counter cold medications also have acetaminophen in it. There are opioid rescue formulations that contain ibuprofen as an alternative to acetaminophen opioid combination therapy. The maximum daily dose of ibuprofen is 2,400 milligrams. A long-acting local anesthetic can delay the onset and severity of postoperative pain, and this is especially true with bupivacaine. Either the regular or liposomal formulations will work just fine in reducing the barrage of nociceptive input, and this can reduce pain scores for days. For those of you who provide intravenous sedation or intravenous antibiotics perioperatively, consider giving a single dose of a steroid such as dexamethasone to limit inflammation. Steroids are anti-inflammatory and act by blocking phospholipase A2, which is the enzyme that liberates arachidonic acid upstream from the COX pathways. There are certain patients in which we must proceed with caution when prescribing NSAIDs. These are patients over the age of 65 years, patients with a history of gastrointestinal ulcers or bleeds, patients with cardiovascular or renal disease, and patients taking anticoagulants since one of the side effects of NSAIDs is increased bleeding. Patients who are taking drugs with a narrow therapeutic window with respect to dosing, such as lithium, may also be a relative contraindication for NSAIDs because lithium is excreted by the kidneys unchanged, and a week of NSAID therapy can increase the blood levels of lithium. So knowing what we know now, how would you approach Neil's postoperative pain following the extraction of his partially bony impacted number 17 with acute pericornitis? Let's summarize with our SMART goals: specific, measurable, attainable, relevant, and timely. That is, what I hope that our audience will take from this presentation to apply to their practice. Recognize that dental post-surgical pain is driven by inflammation and choose your pain management strategies accordingly. Apply a multimodal analgesic approach to minimize opioid requirements. And finally, align pain management practices to evidence-based recommendations for a rational approach to analgesia. Thank you for joining me today for the first of our 3-part CMEO BriefCase series. I hope you'll check out episodes 2 and 3 of the series, where we'll focus on opioid risk assessment and patient education that can be integrated into the preoperative setting to set up patients up for positive post-op experiences. To view additional case-based education on pain management, please visit www.cmeoutfitters.com. Please also visit the Dental and Oral Surgery Opioid Education Hub, where you'll find other dental CE and CME activities, as well as a broad range of resources for healthcare providers and patients. I hope that the case and the data I presented today give you something to consider related to the standing orders for pain management for for third molar extractions in adolescents and young adults. It is a particularly vulnerable time for this patient population, and we all want to ensure that we are making the best and safest treatment decisions for managing their pain. You can click this link to take the post-test and print your CE certificate immediately afterward. Thanks again.